This is very early experience, guys. Literally, we got FUBUKI XF in our shop a week ago, and I'll share with you our initial experience with this. This is our house, this is the team, those are my disclosures. We all know that neurointervention start with the basics, naturally. If you're trying to build a complex flow diverter construct, or what Ansar just showed, intrasaccular flow disruption, coiling. You know, if you don't have the basics, if you don't have good access, you can be set up for failure even before you start getting to your roof. That's the end of your procedure or the pinnacle of your procedure. So access is the basics. So I think FUBUKI XF does offer a super interesting alternative, and we will all learn together where this would fit on our toolbox. But the proposal here from Asahi is to change. I've been using FUBUKI for a long time as a long sheet, a 6 French long sheet, and then FUBUKI XF comes with some features that are different than the regular FUBUKI, where they change the distal shaft to be more trackable and get access to the P2 segment if you want. And talking to the company, I think if we make this longer segment, distal segment that is soft and atraumatic longer, you probably can go even higher. It has a super nice atraumatic tip that I'll show you here that would decrease the odds of you injuring the vessel trying to navigate. And there's a super nice gradual transition there. So this is the FUBUKI XF. And you see here comes in 4 different lengths, 8 to 110. One thing that I think is important, I'm very used to have a millimeter distal tip because of the construct of this distal tip. It's a 2.5, so it's a bit longer. You gotta pay attention to that because you see the distal marker very clear on the X-ray, and you gotta remember that there's a tip that you can also see on X-ray, but is less marked. And the construct of a flat and round stainless steel and tungsten braid enhance the performance. And you see here that the distal shaft becomes really flexible. You see this comparison here between FUBUKI XF and other very good catheters on the market. And you see how the distal shaft performs better than most of the competitors. And you see here when you compare the tip of the FUBUKI, and that's what I was describing to you guys a second. Here you see the distal marker, and you see, for example, here, very short on the ballast. The distal tip is a bit longer and potentially has a benefit on that. Here you see that when you're loading that tip, the FUBUKI deflects easier and potentially less traumatic. And this is the shaft for the whole device. And again, the idea here is to have a catheter that hugs the curve, and from hugging the curve, it decreases the need for intermediate catheters. I'm gonna show you again 5 quick cases here from very basic vertebral artery stenosis. One of the concerns that I have, again, for me, this will be a FUBUKI, regular FUBUKI access. Let's see how the XF perform. Vascular path, typical in our part of the country, right carotid, left carotid occlusion. He has one good vertebral artery and had a posterior circulation stroke, no other embolic source, and this is his left vert. Again, very simple case using a Boston Scientific drug-eluting stent over a Chikai 14 wire. And here you see the procedure. Again, my FUBUKI XF is right here, and I'm gonna cross the lesion. Again, very simple case, but nice and stable, even in a proximal without hugging a curve. The catheter was not designed for this, it's designed to go deeper, but I'm showing you here where you can use that. Nice here, if I need to, I can put my buddy wire there and support my FUBUKI XF. So you saw that result there after the stent is in place, and I'll go next. Going a bit more challenging, and I think this was nice to have a nice, stable platform and be able to aspirate through that. This gentleman came to us with a symptomatic left carotid stenosis, almost like a pseudo-occlusion with intraluminal thrombus. He was stable. We put him on Eliquis for 4 weeks. The thrombus went away, and we decided to do a carotid angioplasty and stent with distal embolic protection using a EmboShield. And you're going to see here, when we're doing our procedure, and the FUBUKI XF is our guide, and here you see a nice bovine arch that was super easy to navigate. And you see here, very delayed flow. So this guy, again, was on Eliquis for 4 weeks. Now there's no intraluminal thrombus. I'm going to cross this with my EmboShield, and I do my angioplasty. And you saw here a second ago, when I did my angioplasty and my stent, I lost flow on the carotid. So we all know, with experience, if you're doing a carotid stent, you lost flow here. In my opinion, 2 things, 3 things: spasm, dissection, or the filter is filled with junk. So I don't have a good way to prove that. I don't want to challenge the system. So I put a nice 58 Navian through my FUBUKI, and I aspirate right at the base of the filter and retrieve the filter under aspiration on a pump. And that did the trick. So here you see, after the filter removal, nice improvement of flow distally. Nice stable platform of the FUBUKI XF, allowing for that manipulation with aspiration catheter without any issues on that. And this is the guy, this gentleman's MRI post-op. Thankfully, he didn't turn a hair and did very well from the procedure. Going a bit beyond that, this is a guy that we treated a couple of months ago with a complex dural AV fistula. We did a multi-plug technique, and we were able to embolize and get a complete occlusion 6 months ago of this fistula. So here's just to illustrate you guys where we are. A dural AV fistula with drainage into a cortical vein into the right transverse sinus. I tried transvenous, could not get my catheter into the vein. And for whatever reason, this stopped playing. Here we go. So this is the left. So we had catheters on both sides, and we embolized this from right middle meningeal artery and from a mini septor on the occipital artery on the left side, and we got a complete occlusion of this fistula. And this is his final result post-embolization then, and then he came back for a 6-month control. This is the fistula treatment. He come back 6 months later for an angiogram, and he has a recurrence of that fed by the occipital. So beauty of this FUBUKI XF here allows me for 2 microcatheters, so I have a mini septor in one branch of the occipital and a Apollo 3cm in another branch of the occipital, and I can do a dual catheter injection and get a quick obliteration of the fistula. I have no idea why this is playing twice here, but we're getting there. So here's our access. This is the retreatment. So you see the FUBUKI XF was parked right here, the origin of the occipital. And now we're going with 2 microcatheters. I did a pressure cooker, so I had my Apollo here, and I go beyond that occipital artery that is going to a normal scalp feeder. I put a coil there, and through that I was able to create my pressure cooker, and then the mini septor that was placed. So this is the pressure, just navigation. I'm going to save time here. That's not the point. The point is that nice stable access that allow for manipulation of micro wires and get your construct with your 2 catheters in position. And here's my pressure cooker being built. Pressure cooker being built. An injection being done. and after my injection is finished from the miniceptor, you have an obliteration of the fistula. So 2 micros, super stable. And I think this is the last case, if I'm not mistaken. This is not actually the case before, the last one is coming. This is just a regular dorsal wall, 43-year-old female with a 6 millimeter dorsal wall, aneurysm of the carotid. So in general, for me, I still like triaxial for flow diverter with a garden variety, depending what flow diverter we're using. This we decide for a pipeline shield, and this was FUBUKI XF alone with a Phenom 27 over an Aristotle 18 for delivery of a pipeline shield. To treat this lady, another bovine arch. Let's try again. SIM2 catheter on the navigating the FUBUKI XF. That's what I think. To have a longer soft tip would be nice, because again, the proximal shaft can create spasm. Was not an issue here. We pre-treated her with verapamil, and we're going beyond that. And the deployment, you saw the opening there of the flow diverter. There was a little ledge at the edge. So you see here, I can bring my FUBUKI XF nice and high, a nice and stable system. I manipulate first to Aristotle 18, was not happy. I decided just to angioplasty. There was a little bit of a ledge right here on the flow diverter. I think a position is very important. And here is the high-perform 4x7, just angioplasty in that completion of the procedure. We do that as a routine for our flow diverters. 2 little hits here, you see here, high on the MRI, but nice and stable platform to deliver flow diverter. And this is the last one, a case that I did just before flying to Japan with my partner, Dr. Aga Ibrahim. This lady came with this ruptured ACOM. You see here the subarachnoid hemorrhage, and we decided to use a web device. She has, it doesn't, the 3D doesn't make justice, but there's a daughter shack right at the neck that we want to cover, and for that reason we oversize a little more than typically we would the web. We all know the web results are related to oversizing the device, better results with that. So we decide for a 4.5 web, and you see here the daughter shack right there. So we went with a FUBUKI XF, and for stability of the catheter for the web, we decided to use a Sophia 6 inside the FUBUKI. I would argue that maybe we didn't have that, but as rupture, I want to have all the stability that I need to do that. So when we deployed the web, it looked pretty good. We always do this as a routine. With any question, we do a 3D cone beam CT, and we thought maybe there's a little bit of impingement. The flow was good. We keep the patient on the table for 10 minutes, and then we see clearly that there's delayed feeling of that ACA, ipsilateral. Patient has a good A1 on the other side. We don't want to roll the dice here. We just decide to save the vessel, and we just go and put an Atlas over XT17 and reestablish flow with a very nice symmetric feeling of both ACAs. With that, I'll conclude, guys. I think the FUBUKI XF is a very good option in our neurointervention armamentarium that has a very nice and stable platform and ability to execute additional steps as needed. I think it's very troublesome when any of us choose an access strategy that locks you out of the next step to salvage the case. I think it's an excellent choice, and I'm looking forward to learn more and use the device more and see what we can do with that.